Good morning, everyone. It gives me a great pleasure to welcome you to this most special and plenary session of Congress 2018, the Enid Graham Memorial Lecture. I've had the privilege of being the chair of the awards committee for the last 3 years, and being involved in the awards process of our profession is an incredibly humbling experience. Through your nominations, we get to see the exciting and diverse accomplishment of our members, and they are truly impressive and special. This makes the task of selecting a single recipient, or for some awards a few, a daunting task. Before we go to the main program, I would just like to take a moment to tell you what your awards committee has been up to over the last 2 years. As you know, we went to a biennial cycle, and over the last 2 years, we've taken the opportunity to look at the awards, and we've done a complete review. Our goal was to ensure that the current awards process reflects our current leaders of today. I would like to take a moment to thank all the members of my committee for their help in doing this. However, we've not done this alone. I would like to also thank the CPA staff for taking a lead in improving the process, improving the transparency, and working to enhance your involvement in our awards. We also received assistance from the CPA board and the CEO in helping us to make sure that we are aligning ourselves with the strategic direction of our association and going forward. So thank you. I would also like to extend a special thanks to one of our previous Enid Graham winners, Dr. Paul Stratford, who's been helping us deal with the process and ensure that statistically we're solid. As you now know, we're on a biennial cycle, and the next full award cycle will be in 2020. So that gives all of you plenty of time to think about who you want to nominate and getting your packages together. The Helen Serenin Rahika Student Leadership Award, though, it does remain an annual award. So if you're thinking about a student, we will be opening sometime later this year those nominations. And finally, I would like to invite everyone to join us at the Wall of Fame. You saw it as you came in right after this, for the presentation of the additional CPA, PFC, and OPPQ awards. So let's go on now to why we are here. The Enid Graham Memorial Lecture is the most prestigious award that the Canadian Physiotherapy Association could bestow upon a member. The lecture was established in 1980 to honor Enid Graham, the founder of the Canadian Association, as it was called then, of Massage and Medical Gymnastics, now the Canadian Physiotherapy Association. The award honors those who have provided outstanding leadership and made a distinguished contribution to the profession, criteria that certainly describes our accomplished award winner this morning. This year's deserving recipient is Alison Hoens. To speak to Alison's accomplishment is Gabrielle Yanida. Gabrielle is accomplished in her own right. She is a clinical associate professor at UBC. She is a professional practice leader at Providence Healthcare in Vancouver, and she also holds an MBA in administration from UBC. Gabrielle, thank you for nominating Alison, and please join us.
Bonjour and good morning. That's the extent of my French. It is my pleasure and privilege to introduce Alison Hoens as our Enid Graham Award winner for 2018. Her impact on the physiotherapy profession and on best patient care has been tremendous and far-reaching. I will only be able to give a few highlights about Alison and her illustrious career, as she has been instrumental in the progression in many areas of physiotherapy practice, education, and research. Alison is a rare individual who excels in her capacity as a clinician, researcher, educator, and knowledge broker. Although BC is her home, Alison's name is known far and wide through her publications, courses, and presentations locally, nationally at CPA congresses, and internationally at WCPT Congress. She promotes a culture of curiosity and inquiry and has driven us to be better clinicians. She's been nurturing the current and future generations of physiotherapists for decades. She has influenced thousands of her peers through her passion and knowledge of evidence-informed practice. Few achieve such name recognition in their career, and it is a testament to Alison's contributions to the profession that she is so well known and admired. She is highly deserving of the recognition that this Enid Graham Award will afford her. Almost every PABC member in British Columbia knows Alison because of her exemplary professional support and contributions that she has offered throughout her career to her patients and her colleagues. Alison began her career in physiotherapy at the University of British Columbia. She graduated with a Bachelor of Physiotherapy degree in 1986. She then went on to obtain her Master's of Science in Health Sciences from Curtin University in Australia. She has worked in a number of roles over the past 32 years, including frontline clinician, pre- and post-licensure educator, clinical specialist, research education and practice coordinator, knowledge broker, knowledge translation specialist, and clinical professor. In addition, she is the wife of Falgun and the mother to daughters Tara and Maya. Her roles have been numerous. Most recently, she has volunteered in arthritis research as a member of the Patient Advisory Board of Arthritis Research Canada. In her role at Providence Healthcare, a cluster of facilities in Vancouver, British Columbia, she's been instrumental in co-developing and supporting best practice in a variety of areas, ranging from acute, rehab, to residential care. She started at St. Paul's Hospital in 1986 and quickly became known as the go-to girl if you needed assistance in tracking down the evidence. She gradually took on roles with increasing responsibility and was instrumental in developing the role of the PHC Research Education and Practice Coordinator position. Her involvement with the academic world parallels her work as a frontline clinician. She became involved with UBC in 1991 and progressed from a guest lecturer to a teaching assistant to a sessional instructor to a clinical assistant professor to an associate professor, and finally achieved the rank of clinical professor in 2012. She's been a regular instructor for PABC courses for decades. As a leader in research and appropriate use of electrophysical agents, her influence has been widespread and has changed how Canadian physiotherapists practice. In 2009, she took on a provincial role with the Physiotherapy Association of British Columbia and UBC as the first knowledge broker in the physiotherapy community Canada-wide and one of the first and few KBs in healthcare in BC. She was awarded this position because her history of leadership and practice vision demonstrated her extraordinary ability to bring teams together, facilitate projects that had relevant practice focus, and showed impressive outcomes. She successfully obtained the commitment of both the Research Institutes for Providence Healthcare and Vancouver Coastal Health in co-funding this position, along with PABC and UBC. This broadened the research base, the clinician involvement, and the reach for outcomes. The work she accomplished year in and year out in creating practical tools for frontline physiotherapists through the engagement of hundreds of volunteer clinicians and researchers was astounding. Her success in this arena led to her secondment in 2017 to the BC Support Unit, which is an organization which has been instrumental in advocating and promoting patient-oriented research in BC. Alison is always keen to mentor others and never, to my knowledge, has ever refused an opportunity to present at conferences and workshops if she knows it will advance the field of knowledge translation, the profession of physiotherapy, and ultimately lead to clinical practice that results in better outcomes for our patients. Alison is an inspiration to both her physiotherapy colleagues and other interdisciplinary professional colleagues who've had the fortune to work with her. Alison has an incredible ability to create coalitions, engage her colleagues, and achieve results that have transformed the way physiotherapists practice. It has been my pleasure, along with Jane Garland, who was the head of the physio school at UBC at that time, now the, I believe, Dean of Health Sciences at University of Western Ontario, Nancy Cho, who is a professional practice leader at Vancouver Coastal Health, and Rebecca Tunnicliffe, who was past CEO of PABC, to be a part of the nomination for Alison Hoens for this prestigious award. Alison has been a long-term friend, colleague, and mentor to me, and I look forward to hearing her Enid Graham speech. Please join me in welcoming Alison.
Wow, there's a lot of you. I wonder actually whether the French translation of this might be preferable to the English version, but here goes. Bonjour mes amis, it's wonderful to be here together in la belle ville de Montréal with colleagues across Canada. Here I stand feeling like I really need somebody to pinch me to make sure that this is real. Many months ago, I received a phone call from Sarah Marshall. I was in a meeting and I ignored the call. And after the meeting, I saw that where the number was from, and I thought, I wonder what this is about. I wonder if this is a project that I've been asked to be a part of. And I picked up the phone and I called Sarah, and Sarah's first words were, "Are you sitting down?" And I said, "I've got a standing desk." And she said, "I think you really need to sit down." And I said, "No, it's okay. I've got a standing desk." And then she told me, and then I really needed to sit down. My first reaction was, oh my God, I can't believe this. That was subsequently moved on to, oh my God, how am I going to do this? And then, oh my God. And I've kind of been in this phase since about August, and this scenario this morning is not helping. I am honored, and there's no turning back. So, first of all, I'd like to acknowledge all the previous Enid Graham recipients. You know, I sat here for 32 years. I've been sitting like you, listening to the Enid Graham recipients and being blown away by the auspiciousness of the occasion. I mean, I had to get my daughter to help dress me, because I don't know how to dress auspiciously or anything like that. I've had the good fortune of working with and being mentored by many of these individuals. And I would ask those that are present today to please stand and be acknowledged. Okay, so I live by the principle that the mind can only absorb what the glutes can endure. And classically, we know from a recent publication, well, not so recent, in the Canadian Medical Journal, that the incidence of nodding off at scientific sessions is correlated strongly with dim lighting, hence the bright lights, a warm room, so we turned the temperature down, comfortable seating, it's not so bad, poor slides, tried to do something about that. Early morning, I did ask for this to be bumped up from 8 a.m. to 9:30 a.m. Monotonous tone, and I dumped the tweed jacket. So the bar's daunting, but the other thing is I'm not very good at pretenses. So the shoes are now off. Before I share a little bit with you about my journey in knowledge translation, I just want to get a sense of who's in the room. So what I would like you to do is when I share a category, if you could silently and quickly stand and then sit. Okay? There might be several categories, so some of you might be standing and sitting several times. So, student, clinician, educator, researcher, physical therapist assistant. Okay, public practice, private practice, community, university, cardiorespiratory, neurology, orthopedics, MSK, pediatrics, geriatrics. Those were a little slower. Amputees, burns, oncology, wound healing, women's health, hemophilia, sports medicine, occupational health, persistent pain. We have quite a mix here, and many people stood many times, a testament to our profession. There's many colleagues here that I've had the privilege to work with in countless projects. Could all of those individuals please stand? And for those that I haven't had the opportunity to work with yet, I'm back in my role in January, so hopefully we'll get a chance together. So how are we going to spend this next time together? I'm going to provide a little bit of context about knowledge translation, and then share with you some concepts, some issues, and then finally some learnings, focusing on what is knowledge, what is translation, what's a knowledge broker, and what can we take from knowledge translation, hereafter I will say as KT, to help our patients, our profession, and ourselves. So, change is inevitable. 5 megabytes looked like this. We now have 5 megabytes in the palm of our hands. Some of those changes, of course, are welcome, some not so welcome. And we accept it as a part of life. So what exactly is KT? Well, this is a very wordy definition from the Canadian Institute of Health Research. And really, you can think of KT as a way of moving a dynamic and iterative process for synthesis, dissemination, and exchange. So it's not simply dissemination. It's in the entire spectrum of creation to adoption of knowledge. So what's knowledge? Well, I'm sure you've heard the term evidence-based practice since, well, at least the last 25 to 30 years. And we've moved from, we hope, positions of eminence-based knowledge to still to some extent, eloquent-based knowledge, evidence-based, and now an appreciation of experience-based. David Nichols from the Critical Physiotherapy Network has recently stated that the PT profession is still in transition, and there's points between each of those that we currently exist. And that if the profession is to make more significant impact, we need to move beyond, but not lose, evidence-based practice. We have a lot to thank for the people who preceded us in recognizing the importance of knowledge, but there's a lot of it. And we thank people like Sir Archie Cochrane, who was the founder of the Cochrane collaboration, who captured the value of knowledge in healthcare most succinctly. But it's not simply the evidence that's in the literature. That's important, but it is not sufficient. In fact, it was David Sackett in 1996, he initially defined evidence-based practice as the conscientious, explicit, and judicious use of current best evidence. He changed that 4 years later, only 4 years later, to move beyond just evidence in the literature to the integration of research evidence with clinical expertise and patient values. All three are integral and collectively form evidence-informed practice. And the relative size of those bubbles depends upon the situation. Okay, so where there's less evidence from the literature, or where the patient's values are not in alignment with a particular approach, the relative size of those bubbles has to change. So what about the second part of that? If we talk about knowledge, then what is translation? Well, Webster's defines it as a restating from one language to another, or changing from one form to another, or the ability to make sense of or to understand, or to express in simple or less technical language. I personally like the language of one of my colleagues as a patient partner, who's the CEO of Canadian of Arthritis Consumer Experts. Her name is Cheryl Cohn, and she simply calls it Greek to street. So how do we know we're doing that well? It's a relatively rare skill to take complex concepts and make them simple. So this paper came out this year in Seismological Research Letters. The title is most descriptive. Do large, i.e. magnitude greater or equal to 8, global earthquakes occur on preferred days of the calendar year or lunar cycle? This is an 18-page article. This is the abstract. But we're faced with a lot of challenges these days, not the least of which is the preponderance of alternative facts. Not all K is effectively translated is credible. Okay? Not all of the knowledge that is effectively translated is credible, i.e., it's not defensible with reputable evidence. The take-home message is just because it's true doesn't mean it's going to stick and get traction. And just because it sticks doesn't mean it's true. You might be familiar with this statement: a lie can travel halfway around the world while the truth is putting on its pants. Funnily enough, this statement has been attributed in the literature to 9 different eminent individuals: Mark Twain, Jonathan Swift, Thomas Jefferson, and Winston Churchill. Most amusingly, it was attributed to Mark Twain in 1919. He died in 1910. But why does this kind of information, why do alternative facts stick? Well, primarily because of the appeal to emotion. Emotion is a wonderful way to get knowledge to stick. You think of something as simple as the water bucket challenge. It had nothing to do with ALS, absolutely nothing to do with amyotrophic lateral sclerosis. But it was appealing because it was something that everybody could do. Everybody had the ability to pour a bucket of ice-cold water on their head and film themselves so they could get that 10 seconds of fame. Okay? There's lots of other examples. Those of you on the Twitterverse may have seen this image. Hands up, who's seen this image? Okay, it went viral. Like 43,000 views within hours. okay, because it appealed to emotion. It turns out that it was the same map, colored, black and white, had nothing to do with mad cow disease. But man, it created interest, and people believed it because they wanted to believe it, okay? Because of the emotion. What else? What else are we faced with in the world of knowledge translation these days? Well, we're faced with confusion. And this is deliberate. It is deliberate because it is effective. And the product is seeding doubt. That you don't have to prove that one side is the correct side or discredit the other side. You merely have to create the confusion. And there's a whole school of science in this area. Let's take one example. Let's look at the measles epidemic that hit Europe this year. In the first 6 months, 41,000 cases of measles in Europe because of the anti-vaccine debate that was created there. There was a study that just came out a few months ago where they analyzed that data looking at bots and trolls on Twitter and Facebook. And the take-home message from this was that you didn't have to, again, show that one side was right and the other was wrong. You simply had to amplify both sides, promote the discord, and create false equivalency. Those of you here in Canada that follow Twitter are probably familiar with the name Timothy Caulfield. Timothy Caulfield is infamous in healthcare for looking at misinformation. And in the National Post this summer, he wrote, "The danger of misinformation is particularly true in the sphere of health, where celebrities and pseudoscience embracing health gurus seems to dominate public discourse." And he showed that Katy Perry has a much more extensive following than the World Health Organization, not to mention Gwyneth Paltrow. So what can we learn from these things? Well, we can leverage this kind of information to deliver our messages in a much more effective way. This morning, I had the privilege of listening to one of the early eye-opener sessions on behavior change in neurological populations to increase physical activity. Why is it so challenging to get people to change their physical activity? How many times is it simply we just need to say, you need to exercise? Why is that so difficult? If we change the messaging, this particular image went viral again. Maybe if we changed it to, well, if you don't exercise, you have a much greater chance of dying than getting attacked by a shark, getting bitten by a snake, or by smoking. The risks of death are greater than smoking. This is the kind of message that sticks. But like everything, we have to be careful about ensuring that the kinds of things that are sticking are based on fact. What about this concept? Hands up. Who has an awareness of where the 10,000 steps per day number came from? It actually came from a company, a Japanese company, for the 1964 Tokyo Olympics. And they manufactured a pedometer that was called the Mano-K, or 10,000 step meter. It wasn't based on any science. Not at all. But we use it all the time. Not to say it's bad. Look, I got one. This is highly motivating for me, but I have to use it the other way to do less steps rather than more. And actually, a recent blog from Dr. Tudor Locke from the University of Massachusetts, she says if we actually look at those 150-minute-a-day guidelines, it more closely correlates with 7,500 steps a day than it does 10,000. I'm not saying don't promote 10,000 steps a day. I'm just saying let's be careful for those to whom that's not possible or is too difficult, because we're unfairly promoting that sense of failure, perhaps. What about this one? We've a lot to be accountable in our profession with this one. Okay, we know from the literature that these two numbers are so pervasive. They stick everywhere. But we know that that number is different for hypertrophy, for strength, for endurance. And we know Kramer's work way back in the 60s established that. So why are we still saying 3 sets of 10, right? And we know that it's not just the number or the number of repetitions or sets, it's also the contraction type. It's also the velocity. It's also the range. It's also the load. So simple numbers stick, but they're not fully accurate. And I think that's captured. So, where do we go from here? There's another really, really important concept that we know from KT. And that's that whether the knowledger is adopted or not is not always based upon the strength of evidence of that knowledge, but also whether it aligns with our current beliefs. And that's called confirmation bias. And what happens in confirmation bias, also known as my side bias, is that there's what the facts say is undervalued, and what confirms our own beliefs is overvalued. So we interpret everything with that lens. The result is we live, like we heard in the opioid section this morning, in silos. We intentionally put ourselves in echo chambers. And social media is designed to fuel that. We like similar messages. And then what happens when we like that is we get an automatic alert to follow other people who feel exactly the same way. And so therefore, it fuels this chamber of believing within our own messages. There is a whole field of science about how to move and the importance of moving out of these echo chambers and the importance of diversifying our networks. I cannot emphasize to you enough how important that is, that we seek out and pursue understanding of divergent views. We have to move beyond, our choice in which selections we attend at Congress is based on, I believe in this, so I want to hear more of this. Perhaps one first step we can make is, I am going to go to a session for something I really question, so that I can learn a little bit more about it, because there probably is some messages within that we need to learn about. So why then what's the message from taking this into the challenges that we face in knowledge translation between integrating research and practice? Please note there's a two-sided arrow there. Knowledge translation is not research to practice. It's an interchange between research and practice. And the value is in the interchange, is in the linkage, that we must learn with and from each other. So this is my definition of knowledge translation. Do not tweet it. Because to me, it's simply understanding that getting can mean developing, it can mean finding, it can mean synthesizing. But essentially, it's getting the information that matters in a way that matters to those it matters to. And those it matters to can be very different based upon that stakeholder group. So Linda this morning said Alison might speak to this. And she was right, because Alison couldn't resist this. I'm sure you've seen this oft-quoted stat. About 17 years to get 14% of research findings adopted into practice. That number is, again, it's kind of like that 10,000 steps. It's not that accurate, because it depends on the knowledge. Some stuff that is really important can make that leap very quickly. But with good KT, and I'm going to share some ideas with you now, that can be not only narrowed in time, but increased in volume. And the key is this. The key is that it's not just about effective intervention. It's about effective implementation, and there's a whole science about that. Effective intervention is the what, but the effective intervention is the how to get to the what. We also need an enabling context. This is where our administrators come in. This is where our decision makers help to create that context. And collectively, though, that's how we get the better health outcomes. So we heard this morning in the session with Kathleen Martin-Guinness that we need to use the science of KT and implementation. And that word is slugliat. I'm sure you've heard of that. It seemed like a good idea at the time. I know, we'll just do a one-pager, or we'll put up a poster, or we'll make a checklist. But what's that based on? It's based on it seemed like a good idea at the time. We've got more than that. We really do have more than that. I'd like to acknowledge that my journey down this field is because of people like Gabrielle, because of people like Sue Murphy, like Rebecca Tunnicliffe, like Jane Garland, who had faith years ago in creating the knowledge broker position. Now, knowledge brokering is a term that I wouldn't recommend you use at a party. It is a great trigger when people ask you what you do and you say you're a knowledge broker. Immediately they need to go and get a drink or go to the bathroom or both. However, if they don't have a viable escape route, I usually use it as an opportunity to explain that a knowledge broker is simply an intermediary. It's the person that lives in the zone between. And if we look at the definition of a knowledge broker, it's someone who helps, not not someone who does, but someone who helps others to move, more than move knowledge, but to transform that knowledge, to help make it more robust, accountable, and usable, to serve locally, and it's deassembling and reassembling knowledge. My journey, as Gabrielle shared, has taken a trajectory that simply, it's interplanetary alignment. I mean, I tell you, I'm not kidding you, I did not plan any of this. I'm not a very good planner. So if we look at the numbers, I'm just an N of 1. I was in the position for 7 years before the recent 2-year secondment. 40% of the grants that were submitted were funded. The normal funding rate is 15%. Clearly, the word knowledge broker on a grant application and helping to write a knowledge translation section of a grant is somewhat helpful. $3 million of funding, 23 projects, 21 resources that have been accessed 250,000 times worldwide. Now that's not because of an N of 1. An N of 1 can't possibly do that. That's because of an N of 400. I've had, this is not fabrication, there's been over 400 patients, clinicians, decision makers, and researchers that have worked on those 23 projects to create the 21 resources. Okay? All right, everybody very quietly and quickly stand up, sit down 3 times. Okay. So now I'd like to shift gears just a little bit and talk about changing behavior. You know, we just talked about physical activity, but what about something as simple as washing hands or flossing teeth? Technically easy, very difficult to get people to do. So let's look at the KT knowledge and behavior change literature around this. Why is it so difficult? Well, essentially because there's a number of barriers to get people to do things, myself included. Okay. It's not just about disseminating the knowledge. In fact, Ballas and Boren have stated that there's a malfunction of passive diffusion. The most frequently cited barriers, I'm sure you can name them: lack of time, too much evidence, not enough evidence, can't get the evidence, can't understand the evidence, can't synthesize the evidence, can't apply the evidence. Well, we can do better than that now. We've got synthesized evidence, but we need to intentionally identify the barriers and then target the barriers with strategies that we've learned from implementation science that specifically address those given barriers. So what are the barriers that we can't face as clinicians? What about this one? This study this year, the same patient had 10 different MRIs of their low back. 49 findings, only 33% of them appearing once. What about abnormalities found on scans in asymptomatic subjects? Disc bulges present in 87% of asymptomatic subjects. Labral tears in 68%. Morton's neuroma, 54%. Half of you have Morton's neuroma, so take off your shoes. So even if the diagnosis was accurate, the next step is we can't just assume that putting the knowledge, we can't just open our patients' brains or our colleagues' brains, put in the knowledge, close the lid, and expect the behavior change. So it's more complicated than just the individual. This is the ecological model. I only have one model. I know that there's at least 130 other models and theories and frameworks, but this one I think is a nice, comfy place to start. In the individual, it's not just their knowledge, it's their skills, it's their attitudes, it's their beliefs. Interpersonally, it's formal and informal networks. Institutionally, there's rules and regulations. In the community, there's relationships across organizations, and in the public, there's policies and laws, as we heard Marcy this morning talk about in the opioid crisis. So let's look at something that helps us to move forward in this. Again, this is one of many. So those of you that this is really appealing to, come and listen to Catherine Harmon and myself on Sunday morning. We're going to give 4 hours of KT. Okay. So the Combi Model speaks to the fact that we can't expect behavior change if we haven't addressed 3 components: capability, which is knowledge and skills, opportunity, and motivation. So let's look at hand washing. Why is it so difficult to get healthcare providers to wash their hands? Okay, they know they need to. They have the skill, they know how to do it. They have the opportunity, there's hand washing stations. If there's alcohol gel in it, then it's there too. So what is the barrier? Simply by putting up a poster that says wash your hands isn't going to change behavior. So that's where we get into the other things. You identify what the barrier is. If the barrier is reminding, then you can use audit and feedback, and you can use reminder mechanisms. If the barrier isn't reminding, like flossing your teeth, what point would it make of having your floss on the counter or a Post-it note on your mirror if the barrier isn't you haven't forgot that you have to floss your teeth? It's that you're not really motivated because you don't see the immediate consequences of it. So behavior change requires planning. You have to know why there's a need, what needs to change, who needs to change, why they should change, and more importantly, how to enable that change. So this one's near and dear to my heart. Compliance, adherence, or the more recent term, commitment. In the therapeutic relationship, we often prescribe to our patients a home exercise program. We know from the literature that we do not have great rates of adherence, compliance, or commitment to those home exercise programs. Now, why is that? Is that because the patient is choosing not to comply? That they've made a choice? Well, perhaps for some. Or could there be other factors that are contributing to that make it very difficult for that patient to move on with that? I want to share a little something with you about personal experience. I'm on team autoimmune disease. 6 years ago, I was diagnosed with rheumatoid arthritis. 2 years ago, I was diagnosed with autoimmune gastroparesis. Despite my training and my passion for physical activities, there were days when, after showering, I did not even have the ability to dry off and would have to go back to bed, soaking wet, wrapped in a towel. I simply couldn't swipe the iPad. I wasn't being non-compliant or non-adherent with my exercise program. I understood the value, I had the knowledge there were other barriers which prevented that. And so we have to be very careful with these labels. And in fact, some of you might have seen this a couple of weeks ago in the British Medical Journal, talking about treatment burden. And this is the concept that the cumulative treatment workload for patients with chronic diseases, when enacting all the recommendations, can be overwhelming. Indeed, calculations have shown that if you look at those collective recommendations and then you interview patients living with chronic conditions, that the average number of hours per month required to manage those chronic conditions, believe it or not, is 51 to 70 hours a month. We need to remember that number because it's often invisible. Treatment burden is invisible to healthcare providers. We tend to underappreciate the burden, and we tend to overestimate patients' capacity. So let's talk about how we can help healthcare providers like ourselves, physical therapists, to move to practice change in a way that's more resonant with the way that we practice as healthcare providers. How many of you have seen this work by Green et al., talking about the 4 different kinds of practice styles? Hands up? Okay. For those of you that haven't seen it, there's 4 different kinds of practice styles. The seeker, the person who actively Googles everything, comes to conferences. You guys are seekers. You are at the conference. There's the receptives who say, oh, yeah, I'm aware of it. I heard my colleague talk about this. I'm interested in it. There's the traditionalist who relies on clinical experience and authority is most important. And the pragmatist who focuses on day-to-day demands and their primary concern is efficiency. Follow-up studies done here in Canada by Kerner-Bratinsky's group have shown that 14% of PTs are seekers. Almost 70% are pragmatists. So why are all of our dissemination techniques targeted towards seekers? We need to use techniques that address the pragmatist. What kinds of tools can we develop that the pragmatist can use to integrate into their everyday practice? Because that's what's meaningful to most PTs. So that's why we've done things like this, an emphasis again on the we. So in 2010, Doctors Pamela Houghton, and Ethne Nussbaum and I, for 3 years, went through a bunch of literature and tried to pull together the information on contraindications and precautions for electrophysical agents. Why did we do that? Because we get so many emails and phone calls saying, for this patient, is this particular modality contraindicated or not? And what we tried to do was provide recommendations that provided information for physios to make their own decisions. Physios are smart. It's darn hard to get into physiotherapy practice, right? To get into training. Really, really difficult. There is no single electrophysical agent, ultrasound, laser, TENS, muscle stimulation, that is always dangerous. Just like there's no modality that is always safe. Just like there's no intervention that is always contraindicated or always safe. It's dependent. And if you have the information to make that decision, you can make better decisions. We can't just memorize a list of things without understanding the rationale behind them. So I'm going to give you an example, and I hope it's not uncomfortable, but it is a vivid example of this. So the guidelines, the UK guidelines for electrophysical agents say that ultrasound should never be used over reproductive tissue. I once got an email from someone asking, they had a patient with Peyronie's disease. Those of you that are familiar with Peyronie's disease, it's like a Dupuytren's contracture of the penis. Now, if you look at those UK guidelines, you would think that, of course, you couldn't break down that scar tissue using ultrasound. However, if you look at the rationale for that being contraindicated, it's because it affects spermatogenesis. And this particular patient was 75. Spermatogenesis wasn't really going to be an issue, and so to deny that person relief and comfort wasn't evidence-informed practice. So, another example, C-spine rules. The silver quill in knowledge translation this year is for this paper. This was a project where a frontline clinician from BC, Marge Below, had said, hey, there's this great rule that helps physios identify if a patient comes in with spinal trauma, whether they need imaging or no imaging. Maybe we should just share it, and then physios will use it, were it to be that simple. 6 years later, we had put together a whole C-spine rules toolkit. Physios told us they were afraid of forgetting, so we did a frequently asked questions and a webinar. Physios told us that they felt there was limited added value, so we did a video with a respected clinician, Carol Kennedy. Physios told us that they didn't have enough time, so we pointed them to the app. And then physios told us that they were concerned about the physician response in sending a patient back for imaging. So we worked with physicians to come up with a template for a letter they could put their own logo on, their own clinic logo, with the language that physicians were comfortable with being sent back to. We have great examples in Canada of great work in KT being done. The most recent one, the iWalk Toolkit that was just released by University of Toronto, showing PTs how to do the 10-meter walk test and the 6-minute test. Does this work? Can we use these toolkits to change practice? So if we look at the Achilles Tendinopathy Toolkit, it got 80,000 downloads all over the world. When we did a survey and asked people who were familiar with this toolkit versus those who were not, people who reported they were familiar with it were more than twice as likely to use evidence-informed tools. So, what else is out there to help us with evidence-informed practice? Some of you might be familiar with this forum where you can, panelists from all over the world, you can enter your question to electrophysical forum and get answers. It doesn't have to mean more time. There's information out there to help us decide which question to ask, which is more sensitive, specific, and has a better likelihood ratio. There's information out there which tells us which clinical tests to use. There's information out there that helps us to identify which are the best outcome measures to use. And there's information out there that tells us what is the value for the clinically significant change. And thanks to people like our own David Walton, we know that that information is vital, and we have to take a look at it and be careful about interpreting it based on its limitations. So, as I wind up here then, I'd like to talk about the lessons learned, what we can take away for this. So first of all, we can't just stop at efficacy studies, what works. We can't just stop at effectiveness studies, what works in the real world. We have to look at implementation studies that address context, settings, implementation issues. And we can't do this alone. If we do not work together outside of our silos, have administrators, researchers, patients, other healthcare providers, people working in biomedical engineering, everyone working with us, we're not going to be designing things the way people use them. People will take their own path. We have to come out of our silos by putting on the shoes of others. In order to put on the shoes of others, we have to take our own off. We have to understand that the natural nature of humans is pendular swings, where something that was super popular becomes totally unpopular. Case in point, icing. Icing was a fundamental principle of physical therapy and then became highly questioned. As we know in the pendulum, the truth probably lies somewhere in the middle. Nothing is always right, and most things are rarely always wrong. So evidence-based physiotherapy needs evidence-based marketing. We have to get inside each other's heads, understanding the other perspective. We have to understand that none of these are separate. We are all one team. We need to know it's not manual therapy versus EPA, or EPA versus exercise, or education, that all of these are fundamental to our profession. We have to embrace our students, and we have to support our students because they are challenged in a way that we weren't. Whilst they have access to unbelievable amounts of information in real time, whereas my generation had to walk to the library, walk down rows of shelves, find the journal, pull it off the shelf, take out pockets of 10-cent coins, photocopy the article, read it that night, and then go back and ask our profs. They now put up their hands before I've finished the sentence and say, but Alison, they get all of this information, but without the context of the years of experience in the real world to interpret what's credible. So it's actually a bigger challenge for them. I would rather have questions that can't be answered than answers that can't be questioned. We have to welcome the questions, not only from our students, but from our patients and our colleagues. So in conclusion, 5 questions that we can really move on for our patients to help our profession for behavior change are: what are the things that you love to do that you don't do now? What are 2 things that you would like to get back to doing? What stops you from doing them? What do you think would happen if you did them now? And what do you think is or have been told is causing this? Several years ago, I was asked to give a presentation that scared me, but not as much as this one. But this scared me. I was given this topic, and it was to be addressed in 11 minutes, and it was to 300 physicians. So, my first slide was, does medicine work? And the example was an article in the Journal of the American Medical Association, JAMA, that showed that a vasodilator for chest pain given in emergency department was 32% effective. Did that mean medicine didn't work? Or did that mean that not all chest pain was due to vasoconstriction or to a particular dose? And then I was able to show, thanks to great research done by great physio researchers, that the right intervention for the right patient at the right dose at the right time was indeed effective. That's our job, that's our passion, and that's our profession. We are all translators. Our patients, if we listen, do a wonderful job of translating to us what's important. Students, clinicians, researchers, administrators, we are all translating every day. So in conclusion, I would like to thank my nominators. I can't believe that these very busy people thought even for a second that this was worth their time to put in the amount of work to nominate me. So I thank them. I thank all of the people that I have professional crushes on in this audience. I thank my patient partners, the people that I've learned from in my sports, and mostly my family, who have been there every step of the way. I also thank all of you, because each of you in your own way gives hugely to advancing this profession. So the one last activity, raise your right hand, flex your elbow, flex and extend your wrist repeatedly. Thank you for all you do.
Fabulous. I'm trying to find her shoes. I'd like to step into them. Alison, I am so glad you called me back. When I rang and had to leave a message, I left a very, a message, just call me back. It's Sarah at the CPA. And I'm sure Alison called me back thinking I had a special project for her to do. Oh, she's asked me to lead some project of some sort. So I did ask her to sit down, and thank you for calling back. As a small token of our appreciation, not only for your thought-provoking lecture this morning, but indeed for your tremendous contributions to the profession and the association over the course of your career, I am pleased to present you with this gift. And the certificate. And as well, I've just polished it up, the Enid Graham pin.